So welcome to the ARCH Network. It stands for the Aging Research in Criminal Justice Health. I'm going to introduce it just because some of you are new to us. The goal of the ARCH Network, which is funded by the National Institute on Aging of the National Institute of Health, NIH, is to bring researchers from throughout the nation and the world together who are dedicated to studying the experiences of criminal justice involved older adults and the drivers of later life health disparities in this population. We aim to support new and established scientists in the development and implementation of research through a national mentorship program for junior investigators, through a monthly seminar series, of which this is one, a bi-monthly seminar series, of which this is one, direct funding for pilot and exploratory research, and by creating opportunities for new multidisciplinary research collaborations, including ones that expand beyond academia, move into academia and community partnerships. So we are thrilled to have two special guests today who are also members of the ARCH Network to speak about the COVID Prison Project, key findings and lessons learned. I'm just going to do a little introduction to each of them, although many of you know them and worship them as I do. Dr. Kathryn Nowotny, who is Associate Professor of Medical Sociology at the University of Miami, where she directs the Miami Health and Justice Lab. She conducts quantitative and qualitative studies to examine the factors leading to increased risk of poor health among justice-involved people and people who use drugs. She is a site PI of a multi-site cohort study examining barriers to PrEP for HIV prevention among people recently released from prisons and jails in the South. She's also co-I on a study examining the impact of immigration processes, including detention and deportation, on the health of immigrants who use drugs, and on a Radix Up initiative. That's the big NIA kind of initiative that's focused on COVID-19 testing and prevention in correctional settings. She is co-founder of the COVID Prison Project, and we're going to hear about that more in a moment. And then Dr. Lauren Brinkley Rubinstein, who is an associate professor in the Department of Social Medicine and the Center for Health Equity Research at UNC Chapel Hill. Her work centers on the criminal legal system in health and how mass incarceration is a structural driver of health disparities. She's the PI of multiple NIH grants, including a cohort study following people on probation and parole who are at risk for HIV. Also a UO1 that is investigating the impact of a peer support intervention on uptake and access to medications for opioid use disorder, and a UO1 to develop best practices for COVID-19 testing and vaccine deployment in jails and prisons. She is also the co-founder of the COVID Prison Project, again, which we'll hear about now. And I'll just say that these are two of the busiest people in the world, and we're thrilled that you took a little bit of time out of your incredibly busy schedule to come and speak with us today. Thanks so much.
Thank you so much for that introduction, Bree. And Lauren and I probably should have coordinated. So two of the projects that I'm on, Lauren's the PI. So we just had different ways of talking about the projects in our bios. So I am going to share my screen and get us started today. Sorry, my phone's ringing. Okay. So we're going to talk to you about the COVID Prison Project, which was, as Bree mentioned, Lauren and I co-founded. Our labs collaborate a lot together, and so COVID Prison Project is one of these. And when we've been thinking about our talk today, we didn't necessarily want to talk about the key findings part of our talk, because I think at this point, everyone's aware, right? That people who are incarcerated are at increased risk for COVID consequences, higher risk for mortality, have less, access in terms, to vaccines and so forth. And so we didn't want to re-emphasize those points. This is like a pretty well-educated audience on those issues. And so we wanted to focus a little bit more on like the genesis of COVID Prison Project, how it started, what was the process, and more importantly, what were the lessons we learned, and then where are we going from here? Like, how are we building on those lessons and moving forward in the future? And so, hopefully this will be of help, to other people. Okay, so COVID Prison Project. Oh shit. I'm sorry, I shouldn't have cussed. Okay, so back at the beginning of the pandemic, like many people on this call probably, Lauren and I had many conversations with others also on this call, such as Elise, worried about how bad COVID-19 was going to be in our prison systems and in our jails. And we started tracking, we were tracking what was happening in our own states. And once, it became clear that this was going to be a long-term pandemic, and it was actually going to enter our prisons and be devastating, we decided to start tracking what was happening across departments of corrections. For all, state departments of corrections, the 50 states, the BOP, ICE, had their own individualized tracking system, and the government was not compiling this information and was not tracking nationally what was happening in prisons and jails. And we felt that was really important to understanding the pandemic. We need to understand the numbers, we need to understand the epidemiology. This needs to be tracked. And so we started COVID Prison Project, and I have, to track cases and policy in 53 prison systems in the United States, including ICE in Puerto Rico, the BOP in the 50 states. And I have on this slide pictures of a number of people who throughout this process have contributed in some way to this project. And I would be remiss if I didn't give a special shout out to people like Forrest and Megan, who are full-time staff members on COVID Prison Project now. Also Chris Corsi, who's done a lot of work in the beginning to help us launch this project, as well as Morgan Maynor, who's the project director of Radix, which we're going to talk about. And then other researchers who've helped us out in different capacities. And so in the beginning, right, when we wanted to start tracking this, we literally had just teams of volunteers. We both had funded research projects with staff that now had nothing to do because all of our projects were shut down, right? We weren't allowed to do research anymore. And so we really shifted our resources to doing manual web scraping. And so this involves literally every day having teams of people go to websites and enter in raw data about the cases, about the deaths, about the number of tests, any information that the DOCs were sharing publicly. And so this, as you can imagine, took a lot of labor, a lot of people hours. It was very intensive. And one of the other challenges that we had was that every single Department of Corrections defined things differently. So they defined like who is recovered in a different way. They defined cases differently. So some cases they defined as current cases, recovered cases, cumulative total of cases. I mean, it was really just sort of all over the place, and there was no standardization. And so we spent a lot of time thinking about how can we standardize these really basic things across DOCs, in order to generate, meaningful numbers, right? To get these key indicators of how many people in our prisons have, tested positive for COVID-19. How many people in our prisons have died attributed to COVID-19, which is very political, as you can imagine, in terms of, we know cause of death, right, is a political process. And not only how are people who are incarcerated being categorized as dying from COVID-19, but how is that data being reported, which varied a lot by states. And so throughout this process, I think we eventually were able to link up with bigger teams of people. So we worked with Melissa Zelensky, which many of you know, who really spearheaded a policy analysis and collecting policy data. Her and her team collected, I think 2,500 pieces of policy from DOCs, including Twitter feed, Facebook updates, policies that were published, newspaper articles to try to track policy changes within these facilities as well. And we also eventually met some computer, I still don't even know, this is like speaks to really my ignorance, but I'm like computer techie type folks who like blew my mind when they taught us about virtual web scraping. And we were able to work with people who could write computer code to actually do, automate a lot of the things that we were doing by hand. And so this also created additional challenges in that, as you all know, anytime humans are involved, there's human error. And so we spent a lot of time then trying to clean our data, make sure, correct any errors. If we found errors, we would check with DOCs, right, and email them to ask, because sometimes DOCs would radically change the numbers and we were able to catch errors for them, right? We would email them and be like, oh, sorry, our person updated the numbers wrong, right? And so I think, thinking about all of this process, so what does this mean in terms of like, what did we learn about research throughout this whole process? And so these are just some lessons learned that Lauren and I put together. And I guess I should have mentioned Lauren and I are going to kind of tag team this. And so Lauren, will jump in and, I'll hand it off to her in a little bit. But thinking about the lessons learned as researchers throughout this process, I think the first one was like the use of technology, which is something I just had never really considered, like what a powerful tool, like website building. We literally had no idea. And now I feel like we're kind of sort of experts in like WordPress, right? And these sorts of things that we don't think about as researchers. And like, what are the possibilities of web scraping? And what are the possibilities of, archiving web pages in case the DOCs take information down, right? Which we were also very much worried about. And then also the importance of branding. And so this was also, I think, the first time for both of us to really think about branding and engaging in the public. And one of my favorite stories to tell about our process is, I think in April of last year, Lauren was asked to speak about COVID Prison Project at a Bernie Sanders town hall on the internet, right? Which was like a big deal. We were like, whoa, this is Bernie Sanders, this is big time, right? And we didn't yet have a website. So we rushed. We rushed and we're working with our teams. We were like, we have to have a website available. We have to like drop the website on Bernie Sanders, right? And we did all of this. We got our Twitter account. We were ready to go. We were talking to website people about like website traffic. We're like, is our website going to crash, right? We had all these like grand ideas that everyone was going to like crash our website. And then Lauren did her talk and we forgot to include the website link in the presentation. I did not even mention it or include it in the PowerPoint, like at all. And that just sort of speaks to our like total naivety about like branding and promotion and these kinds of things that we don't think about. And, it turns out over 100,000 people like were at that town hall, listening to us talk about COVID Prison Project. And we forgot to like plug the website. And so I think, this has also been something we don't think about is like branding for projects, right? How do you brand your research projects to participants? How do you brand it to lay audiences? How do you brand it to people outside your university, within your university? And so I think this has been, really great lesson that, we can talk about more. And then sort of the most, I guess, more important things, right? Thinking about like data availability, transparency, and interpretation. Which we've been thinking about a lot. As I'm sure some of y'all have heard us say before, COVID, in general, prisons and jails tend to be guarded with their data for lots of reasons, right? They don't want to open up themselves to lawsuits. They have data protection, right? They have to protect their own people, right? They can't reveal data to the public, right? There's lots of reasons to be protective over data. But that also means that there's not a lot of transparency about what happens in correctional facilities. And it also means there's not a lot of transparency when it comes to public health events like influenza outbreaks or chickenpox outbreaks or, foodborne illness outbreaks, right? And these kinds of things. Or what are people dying from? As I'm sure many of you know, the United States does, no longer, right, has a tracking system for tracking deaths, right, that occur in custody. And so, but COVID-19 showed that it's possible, right? These DOCs were able to get up like sometimes pretty sophisticated tracking systems on their website that were updated daily, right, through Tableau and through these like really cool systems, And so it's possible. And I think that really showed us like the power, or we learned, right? It really showed us like the power of having this data and being able to hold systems accountable and being able to, we talked to a lot of systems about, systems were learning from us what other states were doing, right? Which I think was also really helpful for them, right? To see like, oh, hey, Minnesota, that was a great idea. Like, why didn't we think of that, right? And just being able to have that information available, not only for the public, but for the systems themselves. And then also for the public. So we would receive many emails from family members that are like, hey, my kid is incarcerated in this facility. Can you tell me what's happening? I'm really scared for them, right? And so it's just all to say that I think we've really came to appreciate data transparency in a new way throughout this pandemic. And then, as I already touched on, like, reporting standards, there are no reporting standards. So it's just really hard to compare across systems, and there's just really no coordination. And I'm sure, this is with COVID-19, and I'm sure that's the case with many other health outcomes or deaths, right, that we could look at. And the final 2 points, and then I'll, see if Lauren wants to add anything, is the importance of engaging policymakers. So Lauren and I had this idea that we started making fact sheets for community activists and organizations, right? So we had fact sheets available on our website, and then we got, I think, 40 or 50 requests from organizations asking us to create timely fact sheets for their state so they could use them for their own advocacy purposes. And so one night, Lauren and I had this idea of, why don't we just email fact sheets to politicians and sort of see what happens. Let's let them know that we're here and we have information about their state and we care. And that's how we got involved with Elizabeth Warren's office. And I think, to date, that has been a really great partnership between academics and policymakers, and being able to, think about policy in really meaningful ways. Using our data, right? Using evidence to think about these policies. And then I think the final thing that I want to touch on is, just reemphasizing the importance of DOC and DOH collaborations. Throughout our data process, we also had many challenges because DOC and DOH data, Department of Health data and Department of Corrections data often conflicted. And it conflicted because of how the DOC was counting cases, how the Department of Health was counting cases. Some departments of health flagged whether or not cases came from correctional facilities. Some departments of health did not. How deaths were tracked, right? If it was the county in which the person died versus the county in which they were sent, the prison they were in, because sometimes you're transferred between hospitals, between counties. And so I think, even disease, tracking illnesses and disease tracking and surveillance, having better integration between the public health departments and Department of Corrections is another, I think, thing that really came out of this pandemic. And so I'm going to see, Lauren, if you want to add anything about these lessons learned to the group.
Yeah, I think the only other thing that came to mind is really this issue, or like the, a lot of the stuff that we did over the last 18 months was it was a majority of like non-traditional academic output. And so I think, when we started this project, neither Kathryn nor I had tenure. And so, that's like, we did this because we care and because we, wanted to make carceral systems accountable. But I think, a lot of the products that we were working with weren't counted in a more traditional academic way. Like, no one in our schools really thought or cared much about like the kind of innovative public-facing dashboards that we had put together. And so I think we had to be kind of creative around like counting and tracking these less academic outcomes. And so I think we've learned a lot of lessons around like how to do that, and how to also talk to traditional academics who traditionally might not care about these kind of things. And so I think it's been like a real year of learning how to work with policymakers, how to use data to inform real world practice, but also thinking about how, in traditional academic centers, how do we innovate on academic processes in a way that's actually helpful for the world and, you know, is more important than putting a manuscript here or there in a journal.
That's a great point, Lauren. And that was something that we've talked about a lot this year. I mean, many of people on this call are in academics too, in early career, you know, trying to get tenure. And, you know, we had to make real decisions about, okay, we have this important finding. We think it needs to get out to the public. Should we publish this on our blog? Should we share it with journalists, or should we save it for publication, right? And some academic journals won't publish something if it's already online, like even on our blog, right, on our website. And so, you know, we had to have those decisions. And I mean, we always erred on the side of like, we need to get this out there. You know, publications can wait, which was our strategy. But, you know, we had to have, you know, but we did have to talk about that, right? And we would sometimes have really important findings. And, you know, we made lots of relationships with different journalists, you know, throughout this process too. And you know, when journalists would ask us for update, we would sometimes, you know, give them our findings so they could publish about it. And then, you know, the consequence, right, for us as like academics would be that we wouldn't be able to publish that finding, which, you know, given that it was a public health pandemic, you know, we were happy to do, but it was still a discussion that we had to have. And thinking about, yeah, like web traffic, like how do you tell your dean about this, right? In a way that'll make them be like, oh, what were you doing this past year during the pandemic, right? Since your projects were stopped, you know, and showing them that you're producing good for the public, right? I mean, okay, so I'm going to turn it. So Lauren's going to talk about now a little bit what's come out of, so like where are we going, right? Or where have we gone from COVID? You know, how are we taking these lessons and building on them to continue moving forward? And so I'm going to turn it over to her, and then I will be the one jumping in.
Okay, great. And Kathryn, you're gonna, good. Okay, awesome.
Yeah,
okay, perfect, thanks. Okay, so talked a lot about COVID Prison Project over the last 18 months and thought this was a nice opportunity for us to talk about Radix and how Radix built on the work that we had done as a part of CPP, and also our new initiative, which I think we're unveiling here for the first time. So you heard it here first, and that is this
like an exclusive.
this is this third city project, which I'll talk about at the very end. Okay, next slide, please. Okay. So I see Lori on this call, and I gave a very similar talk to the Jcoin network last week. So apologies in particular to Lori for having to hear this again. But I thought we would talk a little bit about Radix Up, which used the COVID Prison Project data and the infrastructure that we had built as part of that project to really make the justification for this Radix Up project. And so just Bree gave a little bit of an intro to what Radix is. It stands for Rapid Acceleration of Diagnostics, and the UP stands for Underserved Populations. There are over 70 of these that have been funded, and I think we're one of the only, I know we're one of the only ones that is in any kind of carceral institution, which is in some ways wrong, right? Like I'll just put it right out there, right? Because I think that these carceral facilities have been some of the largest single site cluster outbreaks over time. At any given time, if you were to look, there's always a jail or prison in the mix because the setting, the architecture of buildings, the inherent risk in the environment of carceral facilities really is dangerous in the context of COVID. But we're one of the only ones, I think, that makes us feel like this work is particularly important. We have two aims. One is, the first aim is more formative, so really using qualitative inquiry to get at ethical concerns and potential solutions relevant to both testing and vaccines. And we are talking to both people who work in carceral settings and also people who are incarcerated. And attached to this aim is also a collaboration with the Yale School of Law and Department of History. And we've got an archival content analysis that I'll talk a little bit about. That's a part of this too, really diving into archival documents to bring forward lessons learned or particular atrocities, thinking about how to form best practices, thinking about and looking at history. And then our second aim is really a big data aim. We are in touch with a number of carceral facilities across the country who have given us their data, and we're still in the process of getting that data. We've requested a lot, and I'll let you know what those data elements are in just a second. And I think there's some animation if you click, Kathryn. Okay, and so our main goal here is really to understand, what does COVID-19 look like? What are the ethical issues that have come up over the past 18 months? And how do we move forward relevant to this public health crisis and making us more prepared for the next one? Okay, next slide. Okay, these are where we're at. These sites have been kind of in flux as things have changed over time, but these are pretty solid sites. We've got 5 sites now. We're in a small jail in Yakima County, Washington State. We're in Hennepin County Jail in Minneapolis. We've got data from the whole state of Pennsylvania. We also are working with the whole state of Rhode Island. As many of you know, they have a unified system. So we're working in the Rhode Island Department of Corrections. We're in collaboration with the Department of Corrections in Florida. We're working particularly in 4 prisons in the Miami-Dade area. And we're also working with the Broward County Sheriff, which is in Fort Lauderdale. So South Florida site. So that's where we're working, both relevant to AIM 1, the qualitative work, and AIM 2. Next slide. Okay, so AIM 1, again, is some qualitative work with both people who are incarcerated and people who work in carceral settings. We've changed our, what we said we're going to do a little bit. We proposed focus groups. We decided to do interviews instead. We were going to do sort of like longitudinal interviews over time. We're just doing one-time interviews only. We've done some of these. We've done our interviews with our Rhode Island site and with our Yakima County, Washington jail. And we've talked to both people who work in those settings and people who are incarcerated in both. We did a little bit of a hiccup in Rhode Island. The Correctional Officers Union would not let us talk to correctional officers. We're trying to work on that, but they're a missing source of information in our Rhode Island interviews in particular. And if you click next, Kathryn. Okay, so I'll talk about AIM a little more, AIM 1 in a second. AIM 2, this, I apologize, go ahead to the second. Go ahead and click it, Kathryn. Yeah, okay, and big apologies for this table. I really didn't know how to make this better, but we'll all have to squint and look at it. But the main thing is we're getting a lot of data, and when we're getting it at the individual level, it's de-identified coming to us from all these different partner sites. The big idea here is that we've got incarceration data, some information around facility level information, overcrowding, any information on decarceration that we've got. Then we're interested in COVID specific information. So testing, did folks test? What were the outcomes? And then we've got also some information relevant to other medical information. So we're also getting information from a chart review, medical records relevant to comorbidities, et cetera. Then we're getting policy information. So we're getting policy information that we're doing content analysis on and coding relevant to all the things that you see there. And then we're getting facility level information. So we're interested in like big structural things. So healthcare expenditures, built environment. And we're also interested in some information at the community level. So trying to understand if there's connection, as we suspect there is, between community rates and what's happening in jails and prisons in those communities. And then we're working with some partners at Stanford to do some modeling around a lot of different questions, but really trying to see what are the best types of testing regimens that should be implemented in different types of carceral institutions. We can do that. We can answer the same question relevant to vaccine. And as many of you know, Kathryn and I in particular are really interested in using an abolitionist lens, right? So we're doing a lot of conditions of confinement work, but we're also interested in these bigger ideas of moving toward decarceration. And so understanding things around how many people were released, what do those thresholds look like, really trying to convince carceral systems to move away from status quo. All right, next slide. Okay, so going back to AIM 1, here are the big domains that we were interested in and that we have talked to people about, that we're continuing to talk to people about. General experiences, what has it been like to work or live in carceral settings over the last 18 months? What does medical care in general look like? And what does it look like in the context of COVID mitigation strategies? All the Radix projects really have to focus on testing. And so we've got a lot of information in there around testing regimens, what worked, what didn't work, et cetera. Treatment or COVID response, what happens when someone tests positive? We're really interested in things like medical isolation, quarantine, and how other facets of carceral facilities might impede those COVID responses. And then finally, vaccine attitudes, uptake, and deliberation. Just a note here, I really don't like to use the word hesitancy. I think it's person blaming, and people should be given the space to deliberate. And so I'll use that term, but it's more popularly known as hesitancy. Okay, next slide. As always, like anyone who's ever heard me give a talk, I literally always say like my brain now looks like a social ecological model, which is true. I'm trained as a community psychologist, and so I really am always trying to think of different levels of analysis and thinking about structural inequities and framing mass incarceration as a structural determinative health as a facet of structural racism. And so this is the lens that we're putting on both the big data quantitative work and also the qualitative work as well. Next slide. Okay, here's what we've got to date. So we have done all of our interviews in both Washington State and Rhode Island. These are small though, right? Like these are really different than what we're going to find in Florida in some of our bigger systems. And so we've been doing this work. Here's what the demographics look like. We've done a bunch of interviews in both places. I will say that both Yakima County and Rhode Island are disproportionately white. And so we know that that is a limitation of our work and that these are not reflective of the hyper incarceration in this country. And so that's work that's being done in the other sites to over sample different demographic groups. Okay, next slide. We're also doing this other work. Okay. So here are some of our preliminary findings. I think much of this is not going to be surprising to anyone who's been doing this work over the last 18 months, but I'll just go through a couple of these for you. One of the big themes that people talked about across these two sites is really thinking about miscommunication, issues with misinformation, and how dissemination in general was kind of broken. And so people talked about how there was a big reliance on leadership at facilities to share COVID info, yet leadership often didn't prioritize information sharing, especially for people who were incarcerated, but also for correctional officers. And often any type of communication or information sharing was kind of at the discretion of people who were, on the job that day. And so this trickle down method meant that there were lots of holes in what was actually being communicated. Where we saw high levels of communication or high levels of vaccination, we often heard people say that the source mattered, like who was giving them information relevant to how vaccination worked, how important vaccination was. And so, if it was longtime trusted medical staff, people were more likely to get vaccinated. That's not surprising, but I think that, the trusted messengers, always aren't the ones who are giving that information. And also maybe not surprising, but people who are incarcerated were almost never included in the structure of information dissemination. But there was informal spread of information, right? And so I think there needs to be more information or more inquiry, really trying to see like what are those informal dissemination routes and how do you more formally include people who are incarcerated in dissemination efforts. Movement and isolation. Okay, so like what medical isolation or quarantine looked like across these two sites was wildly different, and it changed over time, right? So sometimes it could look like solitary confinement. Sometimes people were put in medical isolation when it should have been quarantine. Sometimes, it was whole buildings being put on quarantine with little information as to why. So lots of different forms of movement and isolation changed over time, little standardization, limited communication again around like why it was happening, how long it was going to happen. And people also talked about how movement and isolation and no clarity around what was happening contributed to and exacerbated mental health problems. Okay, so maybe I'll keep that at that. Testing, which has really been, it's really the main aim of the Radix work, changed over time, right? So like our own, like everybody's information around what tests work, how should we be tested, how often should we be tested, changed. And that was especially true in the context of carceral facilities. Most places had no access to testing at the beginning, and then lots of testing currently, but it looks different depending on even different facilities on campus. There's also a lot of testing fatigue. We heard that from both staff and people who are incarcerated. So, people who've been tested every week for the last year, we're over testing. And so I think it's really important to think about testing fatigue as a real consequence of doing lots of testing. People also said they didn't want to test because that was often tied to isolation or being put in quarantine. And so that was a disincentive to testing. For staff, we've heard this before, staff really wanted any testing, any, the results of tests to be tied to a sick leave policy. So really a disincentive to testing was, if I'm positive, I'm going to have to leave and I'm not going to be able to be paid. And so lots of staff talked about that. When it came to vaccine, a lot of people expressed deliberation, like being skeptical, but still really expressed openness. Very few people we talked to were opposed and said they were, never gonna take the vaccine. And people wanted more information. They wanted people who were incarcerated in particular were motivated to take the vaccine because they wanted access to programs for life to return to quote unquote normal, and also expressed the desire to protect themselves and others. And also express that testing should be voluntary, right? So by request, by sign up, and it's important again to communicate the reason why vaccine is important both for people who are incarcerated, people that work there, and the broader community. And then I guess I'll also just maybe one thing I'll end with is this ecosystem idea. Again, really thinking about social ecological model. Lots and lots of people that we talked to, whether it was administrators in a prison or jail, or people who are incarcerated or correctional officers, everyone kind of got this idea that the carceral facility was connected to the community. And also this idea of what is healthy for one group is healthy for another. What's healthy for someone inside is healthy for someone returning to the community. And so, I think we've seen that as academics, practitioners, this very clear line between what's happening in the community and carceral facilities. And we've always known that's true. But I think lots of other people have begun to see those connections. And I think people who live and work in these settings especially know this is true and have understood this as a part of their lived experience over the past 18 months. Okay, next slide. Okay, and finally, just a little bit about this archival research. So we're digging into newspaper archives, the archives at Yale, the archives at UNC, relevant to policies, or like there's all kinds of stuff in old historical archives. So we're digging into that, and we've got a lot of sub projects that some staff, some students, some other academics are diving into. And this just gives you a slate of like the kinds of things that we're looking into. There's so much to know. So if you've got an idea around some historical concept, how that might relate to the pandemic, or you're just generally interested in historical archives and public health, you can come work with us and we will figure out how to do this. Some of the things that we're doing is very clearly maps onto the Radix aims. So really thinking about the 1918 flu pandemic and how that applies to current day. Similarly, smallpox vaccine. We also are interested, our whole team, Kathryn, all of us, we've always been interested in temperature and climate change. So we're doing a little bit of that work as well. We're also looking at the connections between solitary confinement health and reform movements, and then also doing some work around HIV, lessons learned through HIV, missteps related to HIV and how that maps onto COVID. Okay, next. And these are some of the things that we're starting to form, the recommendations we're starting to form as part of our qualitative and archival work. None of this is very surprising, but really thinking about how to prioritize sharing and information, how to involve people who are incarcerated in the creation of dissemination tools. Bree has done so much work on getting straight the fact that solitary confinement, if used for medical isolation, is not punitive, and having medical staff run those wards rather than correctional officers. Information relevant to testing. Folks wanted to know their positive results. They also wanted to know their negative results, and also emphasizing privacy. Really thinking about correctional officers as people who have also been in these spaces of risk for the last 18 months and thinking about incorporating them into innovation or intervention. And then also really coming up with vaccine strategies for people who are incarcerated that provides trusted messengers who can give good information and space for deliberation. Okay, next.
I just want to add one thing that, Lauren talked about, there's so much data related to Radix. And, parts of, building on CPP is that, we're working on making all of this data publicly available. I mean, some archives we're creating, some archives already exist. We'll be getting so much data from these DOCs and trying to think about how, like, we're getting de-identified data, but I think we're going to have to de-identify them even further, to make them publicly available. And so I just wanted to add that point.
Yeah, no, I'll say, as a part of our COVID Prison Project data transparency ethos, we've also made all of our COVID Prison Project data available on GitHub, and we keep releasing it, updating it, cleaning it. So if you're interested, it's there. We're also thinking about ways of how to integrate the Radix data into that. We're also taking the COVID Prison Project data and giving it to the CDCC, which is the organizing body for kind of the data hub for all of those 70 plus Radix Up projects. And so all of those projects will be able to integrate community level prison case information into their project. So we are really interested in like going beyond traditional academic notions of like data possessiveness, and want to make our data available to anyone who wants it. And maybe that's a nice lead in, Kathryn, to the next slide. Okay. So we actually just got word this morning that Robert Wood Johnson Foundation funded the Third City project, which is building on the COVID prison project infrastructure. Third City is in some ways social math. It could be the fourth city, could be the second city. We've gone back and forth. The idea here is that if you are to take the number of people who are incarcerated in this country, it would be something like the third largest city. And what the case we're trying to make here is that we know nothing about the third largest city, right? In these other cities, we have census data, we have good information on mortality data, right? But we know nothing. We can't even really identify how many people are incarcerated in this country. And when we might know that, but we certainly don't know it in real time. And so part of the work through the Third City project is similar to COVID Prison Project, really trying to build real-time public-facing dashboards that give information on health conditions, health policies, and also creating a publicly available data set that you can integrate into the work that you're doing, use on its own, or integrate into other nationally representative studies, survey data, some big ideas, some big data around like what's happening in carceral populations across the country. And if you go to the next slide, this is a mock-up of our website that we haven't launched yet because anyway, we haven't launched it, but this is what it will look like one day. We're still, we hate those handcuffs on 3.2 million or whatever. Also, that number's wrong. Anyway, these are mock-ups that we're working through, but this is the general idea. We've done a content analysis of all 53 prison systems. We've gone through all their policy documents, all their monthly reports, all their daily dashboards relevant to population. And we started to categorize, at what interval is health information given to us. And then we're building web scrapers when needed, when it's a lot of static information that doesn't change over time. And then we're building a team that will go in and do some hand entering. And so our big idea is to say, we're web scraping press releases to see how many people died this week. We're looking at annual reports, we're looking at monthly reports. So we can say literally this many people died in correctional facilities this week, right? So really thinking about population and mortality as our two first ideas, but we've also looked at, I don't know, we've literally looked at all health and health adjacent policies. If there's something you're interested in, we'll go out and find that policy and figure out if that information is there, and we'll build it into this project. So it's a big one, but we did literally just get funding this morning. So we're really excited and are also really happy that all the work that all of us have been doing and all the advocacy that we've been doing these last 18 months are growing into this bigger project that we hope is impactful. I think that's our last slide. Kathryn, you can add. Yeah.
Yeah, I say, and so I think one of the lessons I guess we learned that we didn't talk about was what Lauren hinted at was like population denominators, which again, are really difficult to get if you want to calculate something as simple as a mortality rate. And let alone staff data. And so we have found very creative ways to try to find population counts. We've also found very creative ways to try to get at mortality data through sources, not the DOC. And we've also started exploring FOIA requests, which have been, which we're also working on to get additional data. And that has been more successful in some states than others. And so, the idea is we really want to take, as Lauren mentioned, like a real-time, data set, a real-time data dashboard. So people can say, how many people died this week? How many, what is the policies on, housing for trans people? What is the policy around, how they define elderly? What is, whatever it is, right? That we can have it all hubbed, housed in one space, on the internet for researchers, for policymakers, for anybody really to be able to access. So I think
I'm going to jump in, and
I think we're
because we
done.
have 11 minutes, if everybody gives us all 11 minutes, this was fantastic. And just everybody join me in saying thank you. It's really, it has been incredible to kind of watch the COVID Prison Project sort of get born and blossom all the way through the legislation that you all helped so much with Warren's office, and countless, families, and also healthcare professionals inside and outside who supported with this knowledge as well. So it's just been amazing, and you've been like a national treasure, honestly. I don't say that lightly, but I'm curious. I think that I'm really excited to think about the ways that both your data around COVID and also your data through Third City, and I would argue it would be First City if you count the staff, that there, COVID has differentially affected older adults in this country, both in terms of getting it, but certainly in terms of being hospitalized for it and dying from it. And I'm curious to hear whether you've had anybody kind of approach you about collaboration around aging related research, or if you have interest in that sort of collaboration, because I think a lot of people who are on this call potentially would be interested in thinking about that with you. I'll start there, and then others can join in for other questions in the last few minutes.
Lauren, I can address this first, and Lauren can hop in. So I think we have, this is like my brain is like mush there. We have talked to activist organizations about, compassionate release or early release, who've done work around trying to get a release for people around COVID-19 who are geriatric, right? Or at risk for COVID-19. And I think, at least I'll speak for myself, one of the ways I've really thought about, aging in prison with relation to COVID-19 is with mortality. And I think that's like one of the, so we didn't talk about this, but, we don't, which we're going to be able to answer with Radix, but we haven't been able to answer really so far, is we know that age is so highly correlated with COVID and, COVID mortality in particular. And we know that the age structure in prisons is completely different than the general population. And so even being able to do something as simple as like, age adjustments, or like, age specific death rates for COVID-19, or being able to characterize like hospitalization or length of hospitalization, and how these relate to aging, are questions that we haven't been able to answer, but we've talked a lot about and like thought a lot about. And I think, with the Radix, we're going to be able to answer those. And so for me, that's where a lot of my thinking has been with aging. And I think there's, especially with the Radix data, there's going to be so much to explore to see if these association with age that we see in the community is similar, right? And I've done some preliminary analyses to show that like the average age at death is like much lower in prisons. And, we've been able to do this for like small state case studies, to show that the age at death for COVID-19 in prison is structured really differently than it is in the community, which I think speaks to a lot of the work that Bree and others have done about, early onset of disease and things like that. Lauren, do you want to add anything?
Yeah, maybe I'll add briefly that Bree, I see your chat about FAM. We have also been a little bit in touch with FAM, but I'd love to be more formally formally in touch with them. And I think the other thing is that as a part of some of the health policy that we're pulling into Third City, we're thinking about compassionate release, how there's no standardization for what that looks like or how it works across states and systems. And so I think that, it's definitely on our mind.
Great. We have a lot of people in our network who are kind of work very closely around compassionate release, medical parole and policies, and then also, of course, around age adjustment. So if they are interested in getting in contact with you, I will definitely put out an email reminder. Other questions in the next 6 minutes that anyone has? Thanks so much. Don't be shy, people. I know Nick has a question if you all don't.
Question. Well, first, I wanted to thank you both for such a wonderful presentation. I learned so much today. My question is related to the new mandates that the state of California put in place just yesterday, I think it is. How will this impact or affect your work that you do in other states if they follow what California is doing?
Do you mean the vaccine mandates,
Yeah.
Alma?
Correct. Yes. Sorry.
Yeah, that I was going to ask. Yeah. It's interesting. I am like clearly probably in support of vaccine mandates for folks who are working in carceral spaces. I think it'll be really interesting to see who follows California's lead and what that looks like over time. I think in the states that Kathryn and I are both in, that will not happen. And so I think it will lead to pretty disparate outcomes both around vaccine uptake and also COVID. I don't know, Kathryn, if you want to add to that.
Yeah, I mean, I think we could probably take educated guesses on how that'll impact other DOCs. My state, I'm going to say it, was the last state to allow people who were incarcerated to get vaccinated. And they were also the first state to pull public data reporting related to COVID-19 from their website, right? So like, I don't expect that my state is going to care what California is doing, but I do think, it's a good, and I think, we've, through conversations with, correctional officers, I think we've heard mixed things, right? I've had some, correctional officers tell me they want the vaccine, right? They were asking us like, oh, do you have the vaccines available or just test, right? And then of course, we've also heard the other extreme, having to do with, vaccine hesitancy or vaccine myths among correctional officers. So we're also going to see this in the BOP, right? With Biden mandating vaccines for federal employees. And so, yeah, I think it'll be interesting to see what happens, but I think we can also kind of predict which states may copy California and which states may not.
And just to say, Washington and Oregon both have October 18th is when it starts. And so I know that they're all gearing up for a lot of attrition, I guess, from their staff. And so that might be interesting. Mm-hmm.
Yeah, which we've seen with police departments, right? So police departments that have mandated vaccines have seen a lot of attrition in their staff, right? And so we've seen that around the country as well. And, some states like Texas is woefully understaffed right now for many reasons. And so, I think that having the understaffing is a big concern if it doesn't also come with decarceration, right?
Thank you so much to Lauren and Kathryn from the COVID Prison Project and Third City, perhaps First City, and the Radix Up. It was really great to have you here. We're so thankful to you for leading the way for all of us.